Hello, thank you for joining us for the first episode of the Pheo Para Alliance Facebook Live webinar. It's a series where patients and their families have an opportunity to tune in and ask world-renowned Pheo Para experts questions via Facebook Live. My name is Pat Collins. Some of you may know me as a reporter for NBC4 here in Washington. We join you tonight from NIH with Dr. Karel Pacak. Dr. Pacak and the amazing medical professionals here at NIH are the tip of the spear when it comes to Pheo Para's research in treating the increasing number of individuals across the globe diagnosed with this increasingly less rare disease, including myself and members of my family. Dr. Pacak is the chief of the section on medical neuroendocrinology of the National Institute of Child Health and Human Development, which is one of the largest centers in the world to diagnose and treat patients with Pheo Para. Dr. Pacak has dedicated his career to providing the most cutting-edge clinical care and advancing research for Pheo Para. He serves on the Pheo Para Alliance Medical Advisory Board. Thank you, Dr. Pacak, for joining us today, and I want to extend a special thank you to our very supportive partner, Progenics, for making this webinar series possible through an educational grant. The focus of today's series will be metastatic pheochromocytoma and paraganglioma. Viewers are encouraged to send in your questions now via Facebook Messenger. We'll do our best to answer all the questions, but please keep your questions short and to the point. Welcome, Dr. Pacak. Before we open up the forum for questions, our participants now can see an overview of the metastatic Pheo Para. Dr. Pacak.
So good evening, everybody. First of all, it's really great pleasure and honor to be here today. First of all, I would like to thank the NIH as well as Pheo Para Alliance for arranging this seminar. I also would like to thank Mr. Pat Collins for very interesting and very nice introduction. As you heard today, I will talk about metastatic pheochromocytoma, and some work was done here at NIH, but I will also present work from scientists outside the NIH, and not only in US, but also outside the United States. First of all, I would like to say something about the pheochromocytoma paraganglioma in terms of definition. And we know that most of these tumors are located in the adrenal gland, and we call them pheochromocytoma. So it's approximately 75% of patients, they have a pheochromocytoma. Approximately 20 to 25% of patients that they have tumors that are located outside the adrenal gland, and we call them paragangliomas. And paragangliomas are mainly located in abdomen and mediastinum. Those are actually derived from the sympathetic nervous system, and there is very special interesting category of those paragangliomas that are located in head and neck, and they are actually very rare, and these tumors are usually less aggressive, and they have a much lower metastatic potential. Paragangliomas and pheochromocytomas are actually synthesizing and releasing catecholamines. And I have to say that the concentration of catecholamines in PPGL tissue are truly enormous, so 1,000 times higher than in plasma, creating so-called volcano that can erupt any time. And we talk about the episodes, or those episodes are also called storms, attacks, or spells. So what is going on when the catecholamines are elevated? They can actually damage end organs. For example, they can cause cardiovascular damage. Here is, for example, sinus tachycardia. They can cause large intracerebral hemorrhage. We talk about a stroke or ileus. So therefore, all patients with these tumors must receive alpha and beta adrenoceptor blockade to counteract the effect of catecholamines that can be danger for any patient with these tumors. In terms of metastatic pheochromocytoma paraganglioma and its definition, today, based on the WHO organization, the metastatic pheochromocytoma means that there is the presence of metastatic lesions at sites where chromaffin cells are normally absent, and here especially in bones and lymphatic nodes. This is the new definition, and there can be spread of the cells by hematogenous pathway or lymphatic pathway, and most patients have, for example, bone lesions at approximately 60 to 80%, lymphatic nodes about 50%, lung lesions 40%, and liver lesions in about 35% of patients. About 20 to 50% of patients with metastatic pheochromocytoma/paraganglioma die within approximately 5 years of the initial diagnosis. Of course, this is estimate because it depends what you read. Some papers would suggest a lower number, about 20 to 30%. Some papers would suggest a higher number, even over 50%. What is important for these tumors that they are divided into basic clusters, the cluster 1 and cluster 2, and this actually the clusters coming from very interesting observations and previous studies from Dr. Dahia, from Dr. Eisenhofer and others, and here is, for example, cluster 1, and the cluster 1 belongs to Krebs cycle. So remember that all pheochromocytomas and paragangliomas that belong to mutations that are related to Krebs cycles are not good mutations. There are those mutations that usually are linked or associated with complicated, difficult, aggressive metastatic pheochromocytoma. And if I take all these mutations together, the most important one is succinate dehydrogenase that actually leads to increase the succinate, and the succinate affects certain signaling pathway that actually affect the tumorigenesis. Initial studies on metastatic pheochromocytoma concluded that methoxytyramine, tumor size, extraadrenal location, and the presence of SDHB mutation are independent predictors of metastatic paraganglioma. And I would like to show some few data. For example, if somebody has a high methoxytyramine, those patients have much higher likelihood to develop metastatic disease. The most important is also size and location. The size means that if the tumor is larger, then most likely the patient will have a higher likelihood to develop metastatic disease. And approximately the size is about 5 to 6 centimeters. So whatever is over 5-6 centimeters, it's worrisome, and the physician should know about it and should tell patient that there might be, increased frequency of metastatic disease. The same is for the location. We have either the adrenal tumor, and I told you about that because the adrenal tumors are called pheochromocytomas, and they are more benign. They behave in a better way. But then we have extraadrenal ones called paragangliomas, and they are those that are definitely more complicated, more difficult, and again, all patients should be told that if they have an extraadrenal tumor, they will most likely have higher chance to develop metastatic disease. So if we go back to the Krebs cycle, and I told you about the mutation, that there are some mutations, but the most important are related to succinate dehydrogenase, and succinate dehydrogenase has 4 subunits, A, B, C, D, but the subunit B, D, and A are the most important. When we talk about the B, just sometimes remember B as a bad. And because they don't behave well, they are aggressive. And as I mentioned on my slide, most of them are extraadrenal, abdominal, aggressive, multiple, metastatic. What is interesting for this type of mutations in paragangliomas or pheochromocytomas, they produce, for example, norepinephrine and dopamine, and if they are approximately 3.5 to 4 centimeter, the likelihood to develop metastatic disease is higher. So if you remember the previous slide, when I talk about 5-6 centimeter, I talk about those tumors in general or sporadic pheochromocytoma paraganglioma. But when we go to SDHB, we are already afraid when these tumors are between 3 to 4 centimeter versus, for example, sporadic, that the size is approximately 5 to 6 centimeter when it's becoming metastatic. Those tumors are also located in very interesting, unusual locations. For example, they can be mediastinal, they can be in organ of the candle, cardiac paragangliomas. In 78% they have a SDHB mutation, or urinary bladder, approximately 50% have SDHB mutation. What you have to know and what your physician should tell you, that those mutations are coming also with kidney cancer, and approximately 14% of patients may have a kidney cancer. For the SDHB related pheochromocytoma paraganglioma, they are located mostly in the head and neck area. They can be multiple, rarely extraadrenal. The biochemistry is interesting because they usually do not secrete norepinephrine or epinephrine, but they produce the dopamine and its metabolites, which is called methoxytyramine. As I mentioned before, the head and neck paragangliomas are rarely malignant, and we should operate on them when they are approximately 2.5 centimeter or larger. But if they are related to SDHB mutation, we should operate them a little bit earlier, and the size is approximately 2 centimeter. The kidney cancer is also related to SDHD, and there is paternal transmission. So in other words, means that you can get actually this tumor from your father, but you cannot get the tumor from your mother. And there are the SDHA, that are very interesting entity. They are very rare ones. Sometimes I say A as an awful, and I will tell you why. Because there is very high malignant potential, up to 70%, and even they have a very low penetrance, there is no family history. So it's very difficult actually to get those patients early enough for examination and for diagnosis, because they don't simply know, because there is no family history, and most of them are extraadrenal. There are some other risk factors except for what I said about the SDHB, and I would only say that, for example, telomerase activation as well as ATRX mutation. Why I am saying that? Because if your physician will tell you that the pathology report came back and there is SDHB mutation, and together with ATRX mutation, which was discovered by the Dr. Fishbane and Nathanson, is very important, because these patients most likely will go into very complicated, difficult scenario, which equals the development of metastatic disease. And there are some other studies, for example, about the TERT as a catalytic subunit of telomerase that is also related to metastatic pheochromocytoma paraganglioma. Sometimes patients will ask me, what is my chance to get or to develop the pheochromocytoma paraganglioma if, for example, I have a SDHB mutation? And I think that this is a very important question, especially for their children. And there is some interesting study that came from the Netherlands, and they said, that the likelihood is not what we thought before, about 50 to 70%, but it's about 20%. And what is good for this study, they found that to develop metastatic disease is somewhere about 10%. Our group also investigated the SDHB carriers, and we came up with a little bit higher number that was approximately 20 to 25%, but I wanted to tell patients that if they are carriers, they should not be afraid with the numbers like 70%, 80%, because these numbers are lower. So the penetrance, so the chance to develop actually paraganglioma or pheochromocytoma if you have a SDHB gene mutation, which means that you are carrier, and if we go, for example, for the age 50, that the likelihood is about 16%. So I think that these data are definitely promising. There are some mutations also that they are good mutations or bad mutations. I will not go into details, but definitely your physician or your geneticist should look at the mutations and to give you, some background about these mutations and tell you what can be your risk based on the specific type of mutation. There was some interesting recent meta-analysis that included 703 patients, and there was the multivariate analysis and look at the association of metastasis with the SDHB or some other parameters, and they found that SDHB is definitely something that is important to develop metastatic disease, which I said already before. But what is new here, that the high norepinephrine or dopamine or both, so which means if you have a paraganglioma or pheochromocytoma secreting norepinephrine and dopamine, you have a higher chance to develop metastatic disease. This is somewhat new. And then the survival of those patients who have already a disease or metastatic disease is related to age and of course the number of metastatic lesions, and again to hypersecretion, which I mentioned before about, for example, norepinephrine and dopamine. I like this slide that is showing there are some new risk factors to predict survival. Because if we have actually the pheochromocytoma paraganglioma, it's metastatic. The second question that is coming from our patient is, what is actually my chance that I will die? What you can tell me about the survival? And the survival is affected by age. So older patients are not doing so well. Also multiplicity. So if the patient is presenting with several tumors, the chance actually to survive is lower, and also it depends what kind of metastatic lesions are present. If they have a distant metastatic lesions, which means, for example, organ metastatic lesions, then the survival will be definitely lower. So the pheochromocytoma and paragangliomas are very important because they can be imaged. I sometimes say that the pheo and paraganglioma, they were born actually to be imaged, and the reason is that they have a certain transport system or receptors that can be used for the specific imaging modalities. And we know, for example, about the MIBG, that is very well known because the MIBG goes through norepinephrine transport system. We know about the FDG because there is glucose transport system, but the FDG is not something very new, because the FDG can be used for many tumors that have a glucose transport system. They have an amino acid transport system, but what is important, they have something which is called somatostatin receptor. And this somatostatin receptor is very important because it's overexpressed on pheochromocytoma paraganglioma, so we can use certain analogs to image actually these tumors. And this is shown here, that if we use, for example, and this is the first patient that we did at the NIH with SDHB related metastatic paraganglioma. If I would do fluorodopamine octroscan, that is very well known, or MIBG, I told you before, so I would not see any lesions. Most likely I would say to tell patient, go home, you will do well and come in 1 year. If we would do fluorodopa, which is not really available so well in the United States, you would find some lesions, but we would say to the patient, maybe take some medication, but you still will be okay. I do not need to see you immediately. But then what we did, we used the dotatate for the first time here at the NIH, and you can see how many lesions the patient has. This is the completely different approach to this patient. We needed to start the therapy immediately because this patient cannot be told to come, let's say, in 3 to 6 months for follow-up. This patient needed to be treated. So then we did some studies, especially focusing on metastatic pheochromocytoma paraganglioma, and both actually group, the SDHB-related metastatic, as you know, because SDHB is related to metastatic disease, but also there are a lot of sporadic pheochromocytomas and paragangliomas. They present with metastatic disease, and you can see the dotatate compared to any other studies is the winner. So the dotatate was found and was incorporated in new imaging algorithm and new imaging guidelines that we actually presented just a few weeks ago and published in new imaging guidelines. That dotatate is the most important imaging modality for metastatic pheochromocytoma and paraganglioma. Why it's important also to know about somatostatin receptors? Because we can use them for theranostics. The theranostic concept is interesting, was pioneered by John Funkhauser, and actually combined two parts. One is diagnostic. Diagnostic is that you use the method to diagnose the tumors, and therapeutics to actually do certain therapy. And this is what we are using right now to combine the diagnostic approach as well as therapeutic approach. And we can use certain radionuclides that are very important currently for clinical use and for patients in the United States as well as outside the United States. We can use lutetium, iodine, and yttrium, and I will show you some data. The first, I can tell you something about AZEDRA, which is manufactured using the novel ultratrace process. What does it mean? We have conventional MIBG, which is MIBG with iodine 123, but has very low specific activity, which means that if we inject this radio compound, most of this radio compound is cold, which means that does not have the radioiodine, and only very small amount of molecules are actually labeled with radioiodine, and which means that we are talking about low specific activity, which is about 16 millicurie per milligram. So about 7 out of 1,000 MIBG molecules are labeled with iodine 131, so which is very low. But there is a new process which is called ultratrace process, has high specific activity, and virtually every MIBG molecule is labeled with 131 iodine, and this is a very good step forward when we can really efficiently treat patients. So when we compare conventional with high specific activity for the iodine 131 MIBG, data suggests the better partial response and stable disease using AZEDRA. AZEDRA is convenient because we use 1 or 2 treatments compared to conventional therapy when we are using about 3 to 4 or 5 treatments. AZEDRA may not be, however, good for those who are older or have some comorbidities, and not good for patients who have a low blood count because there is certain hematotoxicity. And there are about 10 centers just now providing patient with AZEDRA, but the long-term effect related to one-time high radioactivity is still awaiting some evaluation. I told you about the somatostatin receptors, and you can see not only neuroendocrine tumors, abbreviation is NET, but also PPGLs. They have a high somatostatin receptor, especially number 2. How we can use them? We use them using dotatate, lutetium 177, Lutathera, and this is the treatment for unresectable or metastatic paraganglioma. The study came from Australia, and 20 patients were included. Median is about 4 cycles given apart 6 to 8 weeks, so the total radioactivity is about 800 millicuries. And you can see that about 8 out of 14 patients treated for uncontrolled hypertension required reduced medication, which is very good. And of the entire cohort, 36% of patients had partial disease regression and 50 were stable. So altogether is 86%, which is absolutely fantastic, with progression-free survival about 39 months, and adverse effects are really not bad, with some lymphopenia and thrombocytopenia. And there is another study that actually combined the Lutathera with the capecitabine, and again about 84% of patients had partial response or stable disease. So when we look at the Lutathera and when we look at the Azedra, what is better? That based on this actually slide, we can see that approximately 84% of patients, and we have actually the last paper from Dr. Zandi from the Netherlands, it's about 89%. And when I look at the Azedra, it's about 92% had partial response or stable disease. It's practically the same. So both studies are really working very well in terms of radiotherapy of metastatic pheochromocytoma paraganglioma. Finally, I would like to say that there are some other treatment options for metastatic pheoparaganglioma. Is old CVD, cyclophosphamide, vincristine and dacarbazine, but only 35% of patients will respond. But there is exception. If you have a SDHB mutation, 70 to 80% of patients will respond. We can use temozolomide, we can use metronomic temozolomide, capecitabine, together with temozolomide, which is very interesting, octreotide or lanreotide. We cannot use, for example, Lutathera as a radio treatment, because octreotide, lanreotide is like our cold analog for somatostatin receptors, tyrosine kinase inhibitors. But the patients sometimes may have a honeymoon period. They are doing very well at the beginning, 6 to 8 months, and they can get much worse. Or, of course, external beam radiation, especially in those that we cannot actually reach the lesions very well, for example, for head and neck paragangliomas, or they have a bone lesions and they have a pain and they need immediately relief. So I would finish my presentation to thank to all NIH members. And there are laboratory scientists attending, and the endocrine oncology, surgery, pediatric radiology, and ICU fellows for their dedication, passion, and really long hours of effort towards those who suffer. Many thanks to current outside NIH co-investigators, organizations, and many others. And I would like to finish is actually quote to the word, you may be just one person, but to one person you may be the word. And this is why we are here, to help those who suffer and to help them, to return them to their families and to be again, with their loved one. Thank you so much.
Wow, Doctor. I think you've really done your homework. That was very, very impressive. To all the people out there watching us now, can you tell us what are the symptoms they should look for if they think they might have a Pheo? What are things they should look for before they go see a doctor?
Yeah, so there are some very typical and specific symptoms related to pheochromocytoma. As I mentioned before, those tumors are producing and secreting catecholamines, and the catecholamines may affect different organs. So usually patients are coming with high blood pressure. The blood pressure cannot be very well controlled. So if the blood pressure is there for 4-6 months without very good control, or if the patients they have about 3 or more antihypertensives and there is still a high blood pressure, that is definitely worrisome, especially in those who are younger and who do not have any predisposition. For example, they are not obese, they don't have a diabetes or other conditions that could cause hypertension. Another problem is that because they have a hypertension, and sometimes they don't know because they don't measure their blood pressure, they can have, for example, headaches, and they have a sometimes very severe headache, either in frontal area or occipital region. The other problem is nervousness, anxiety. Very often they will tell you, I'm nervous or I'm anxious for unclear reasons and I don't know what is going on because I never had this kind of problems before. Then they can have a sweating. Sweating is very interesting. Sometimes we forget about the sweating, but the sweating comes very often in patients not only during the day, but it's coming during the night. They have a drenching sweat. They are actually waking up and they have to change the sheet. They have to change bed because the sweating is really profound. So this is another problem. Sometimes they can have visual problems because the catecholamines affect actually ocular muscles, and they will go to doctor and they will say, you know, doc, I need actually the different glasses because I don't feel comfortable and there is something wrong with me and it changed just during the last maybe few weeks or 1 month or 2 months. Those are the most important symptoms and signs that are related to catecholamine excess.
And that's when you should go see a doctor right away.
And that's when you should see the doctor and you should explain to the doctor. And if you tell the doctor that you have a high blood pressure, you have a sweating, and you have a palpitations. Palpitations mean that your heart is beating fast and there are the episodes, and the episodes are for 1 minute, 2 minutes, then they disappear. They come back, in a next day or in a 1 week or in a 2 weeks. That is very worrisome. All the doctors should think about the pheochromocytoma. Not everybody will have a pheochromocytoma because these tumors are extremely rare. But what is important to think about the pheochromocytoma? Once we rule out Pheo, it's good. We don't rule out Pheo, and the Pheo is there, it can be devastating, and the patient can end up with very complicated and serious health problems.
Now, we have a question coming in. This was considered a rare disease, but my understanding is here at NIH, you're getting more and more patients with Pheos. Is it really rare, or is it just being diagnosed more?
Yeah, so definitely is the rare disease, and because the rare disease is usually the disease that there are not more than 100,000 patients in a certain society. So pheochromocytoma belongs to rare neuroendocrine tumor. In terms of number of the patients here at the NIH, it depends, but I would say the average over several years will be approximately 300 patients. And I am talking about the new patients as well as those they are coming for follow-up. Yes, it's true that we can diagnose pheochromocytoma earlier, and the reason why we can diagnose them earlier is not that maybe the incidence would be higher, but I would say that we have better tools to diagnose pheochromocytoma paraganglioma. I mentioned something about the metanephrines. I mentioned something about the methoxytyramine. I mentioned something about the new imaging studies. They all are helping us to find pheochromocytoma a little bit earlier and to help patients. Because what is important for these tumors, and then not only for these tumors, that many other tumors, many other cancers, early diagnosis is very important. We can help patients if the tumor is small. If the tumor is large or the metastatic, the help is definitely limited, and we don't have many options, and treatments are limited how to deal with, for example, patients who have a metastatic disease.
Now, Kate's on the line, and she asks, how can someone interested in being treated at NIH reach out to you or your team?
I think that can be done pretty well. They can reach me, and as you remember at the beginning of my presentation, I put not only my name, of course, but I put my telephone number as well as email. So it's not problematic to reach me, and I will answer. My policy is here at the NIH, I will always answer in 24 hours except when I am traveling. If you cannot reach me, you can call also NIH operators 301-496-4000, and you will be connected either with me or with my nurse practitioner or a research nurse. The name of my nurse practitioner is Marianne Nu, and the operators know, and they will be very happy to connect you with us, and we will be happy to talk to you and to assess you, for example, if you send us some medical records and everything, and to tell you whether you would qualify for our pheochromocytoma paraganglioma here at the NIH.
Lauren's on the line. She says she'll be starting MIBG treatment soon. She recently gave birth and is breastfeeding. How long will she need to be in isolation? And is the isolation a one-time thing, or will there be multiple isolations?
So first of all, if you gave birth to your child and you are breastfeeding, you cannot get MIBG. So the MIBG is contraindicated. There is no way that you should get the MIBG, number one, okay? So, and if you stop breastfeeding, it should be at least, for 6 to 8 weeks, and then you will be able to get the MIBG treatment, and it won't be any problem whatsoever, but no breastfeeding.
So should she do the breastfeeding and then the MIBG treatment?
She should finish the breastfeeding first. She should wait for approximately 6 to 8 weeks after breastfeeding, and then she can receive the MIBG treatment.
Another viewer says, or writes in, have any new genes been found that involve excess red blood cell production?
Yeah, that is actually my favorite topic. Of course, they were. The first gene was found, and this hypoxia-inducible factor 2 alpha. And this gene actually was found in 2012 and was published as a new gene that is associated not only with paraganglioma or pheochromocytoma, but also with another neuroendocrine tumor, which is called somatostatinoma, and polycythemia. Polycythemia means the high red blood cells. From that time, we found another 2 genes, and one is so-called PhD1, and another one is IRP1. So, and previously, French scientists found PhD2. So, there are at least 4 genes that can cause actually the high red blood cells as well as paraganglioma, and in some cases also other neuroendocrine tumors.
Sally from Bethesda wants to know if anxiety and or unprovoked panic attacks with profuse sweating without chronic hypertension are indicators of Pheo-Para.
Yeah, they can be, definitely, especially in somebody who never had anxiety, never had any nervousness, was really doing very well, more cool personality, never upset, never nervous, and just coming suddenly. So we should be definitely suspicious. They can have also panic attacks, but we have to be very careful between the panic attacks and real diagnosis of pheochromocytoma/paraganglioma. Because what is important, if somebody has nervousness/panic attack related to pheochromocytoma paraganglioma, then the catecholamines will be high. It will be elevated. If somebody has a panic attack and does not have any presence of pheochromocytoma paraganglioma, those patients will not have elevated catecholamines. And if they will be elevated, they will be elevated only slightly compared to presence of pheochromocytoma paraganglioma, that will be definitely high. So biochemical diagnosis is must, it's important, and can help distinguish these 2 entities.
And they do that by collecting, don't they collect your urine for
Yes.
24 hours?
Yes,
and
they can do both. They can do the plasma or they can do the urine. So either way, so some hospitals cannot afford to do the plasma and vice versa. So either way is okay. We prefer here at the NIH plasma because we think it's more accurate. But if it is not available, urine will be okay also.
Katrina asks, are there any over-the-counter medications or vitamins that will improve the tumor microenvironment to help the drug therapies be more productive? For example, Katrina is taking CVD chemo, and I don't know if I'm pronouncing this right. Cabozantinib?
This is cabozantinib, so
He's the doctor.
it should be cabozantinib actually. So I would say that in terms of taking some medication or vitamins, I will always suggest to take something that boosts actually immune system, because if you are taking chemotherapy, your immune system is actually shut down. So you should have the medication that actually support immune system, and you should talk with your doctor or pharmacist, and I am pretty sure that they will be able to give you some suggestions what to take. In terms of vitamins, yes, I would definitely suggest to take vitamins, and the best source of vitamins is to take fruits and vegetables. And that would be really the best as much as possible, because they are also antioxidants and they are helping to fight cancer cells. We have just now new study. We have not published the study. We will see. It is under revision, so I don't know what's going to happen with the study. But it was done with the support of the NIH, looking at the vitamin C in certain type of the pheochromocytomas and paragangliomas, especially those with SDHB mutation, and we have some very interesting, promising results. So maybe in the future, and I'm saying maybe, vitamin C, and especially high doses of vitamin C, can be of the interest. But of course, we will see, what will happen when we have all the data, and when we think about some maybe other experiment that can help us to highlight the effect of vitamin C in these patients.
So drink your orange juice.
Drink the orange juice, but the fresh orange juice, not something that you will buy over the counter, unless you know that this is really something very good and full of the antioxidant.
All right. Mark, he calls in and wants to know, what are the chances of paraganglioma recurrence post-op, with his following details? He's clear of all the genetic markers. The original tumor was benign, inactive, but the size was large, the size of a fist, he says. It was located posterior help me with
mediastinal.
Mediastinal. With those chances of recurrence, what are the percentage it became metastatic?
Yeah, so it's first of all, yes, the tumor, if I am reading it well, was large tumor, was approximately about 5 centimeters. It's in the mediastinum, so which is the area that is definitely worrisome. I would be happy to look at the genetic testing, because many of these tumors sitting in the mediastinum has actually genetic background, so it will be important what kind of genes were actually assessed, and but the tumor was already large, so and you cannot say whether the tumor is benign or malignant, because there are no histopathology criteria to say that the tumor is benign or malignant. Yes, there are some scores, but the scores are not perfect. So I would say that this patient will need definitely very good follow-up, and I would like to know whether the tumor was biochemically active or not. If the tumor was secreting, for example, noradrenaline or norepinephrine, which most likely it secreted norepinephrine or dopamine or both, I think that that would be definitely a risk factor to develop metastatic disease in the future. So very good follow-up, and at the center that has very good experience with these tumors would be definitely advisable.
So Mark should get regular checkups.
Definitely regular checkup, and if the operation was recently, the first regular checkup should be done between 3 to 6 months after the operation.
This is from Cheryl. Is it always stage 4 when it spreads to the bones? And then what's the life expectancy?
So we sometimes don't talk only about the stage 4 or stage 1, 2 or 3. This is not what is typical for pheochromocytoma paraganglioma. But I can tell you something. If your tumor spread into the bones, you have better chance for the survival, because there are actually two options. One option, if I don't take the combination, so one option that these tumors can spread into the bones, and this is more favorable prognosis, versus if metastatic lesions, they go, for example, into the organs, especially in the liver. This is very worrisome, as well as into the lungs. So liver and lungs, we call them, those patients, short-term survivors, compared to those that they have a bone lesions, they are long-term survivors. So if you have a bone lesions, and especially few bone lesions, the outcome can be very favorable.
Renee, thanks for joining us and taking time to discuss Pheo Para. She wants to know if surgery is an option for a Pheo that hasn't metastasized. How does one decide between radiation or surgery?
So if the pheochromocytoma did not metastasize, we should always think about the surgical procedure, because only the cure of these patients having either pheochromocytoma or paraganglioma is the surgical procedure. So if surgery is feasible, and it's not feasible always, it depends on the location of the tumor, it depends on the size of the tumor, and of course it depends on comorbid some problems. But if the surgery is the option, we should definitely think about the surgery as a first. If the surgery is not the option, the patient needs to present to very good specialist with very good experience in these tumors to find out whether, for example, chemotherapy is needed, radiotherapy is needed, or something else needs to be done. And there are several options what can be done. So it's not sometimes easy to decide what kind of treatment modality to be used, but as I said before and several times, surgery should consider as a first treatment option, and especially if it is feasible, should be actually performed.
Get that tumor out of there.
Yes.
Question from Jim. He says he had a ruptured Pheo and subsequent removal 4 years ago. The rupture caused it to break into 3 main pieces. Does this increase his chances of the Pheo seeding from any cells that were left? Is there anything he should do over these yearly tests?
Yeah, some pheochromocytomas can rupture, especially those that are big, and I'm pretty sure that Jim had most likely bigger pheochromocytoma, because I cannot imagine that, for example, pheochromocytoma 1 to 2 centimeter will rupture. I haven't never seen that. But over 20 years of my career dealing with patients with pheochromocytoma as well as paraganglioma, we saw rupture tumors maybe 5 times or 6 times, and those were at least 5 or 6 centimeters. If you have a rupture of the tumor, of course, many cells will be actually released into the circulation, and there is a higher chance to develop a metastatic disease in the future. But I have to be honest, there are no any studies that would assess those patients whether, for example, if we would follow them up for 5, 10, 15 years, had higher likelihood or frequency of metastatic disease, because this is very rare. And as I said, over 20 years I had maybe 5 or 6 patients, but I would say that definitely there will be higher likelihood to develop metastatic disease. The checkup is very important. You have to have yearly measurement of catecholamines and metanephrines. This is must.
We hear from Charlie. He says he's taken an alpha blocker, doxazine, which seems to be making his panic attacks worse. Is this common?
Taking actually doxazine and making panic attacks worse is not very common. And I don't know what is going on. I would like to know if actually he's taking anything else except for doxazine, because the doxazine usually is not usually causing panic attacks. So maybe the patient is also taking some other medication, like for example beta blockers, because doxazocine is alpha blocker, and often patients with pheochromocytoma paraganglioma, they need both alpha and beta blocker. So here I am not absolutely sure. It's difficult to answer for me this question unless I have more information and more details.
Charisse, she says she had a carotid para removed in 2013. Her father had one in 2007. Are blood tests good enough for a yearly follow-up?
Yes, definitely there is the genetic disorder, and there is, the gene. We don't know what kind of gene. I would guess that there may be SDHD, perhaps, SDHB, and the follow-up should be the measurement of plasma metanephrines and catecholamines. At the beginning, usually when the tumor is found, I suggest, or for example removed, I suggest to be done every 6 months. And later on, after maybe 2 years or so, and it depends how the patient is doing, to do it every year. But because there is the family history of pheochromocytoma / paraganglioma, I would also suggest whole body imaging every 2 or 3 years, and is either CT or MRI. I usually like to alternate, once CT scan, let's say every 2-3 years, and then another 2-3 years MRI, because we can avoid excessive radiation.
How easy is it, Doc, to get those kinds of scans? Let's say if you're, if you live in Montana, is there a hospital that will do that?
Yeah, I think that's excellent question. I think CT scan and MRI scan is available practically everywhere. I think that would not be the problem for patients, especially with history of pheochromocytoma paraganglioma, to get, for example, whole body CT scan or MRI scan. Of course, we are limited with insurance, and that can be the problem. But another imaging studies, and I was talking about, for example, especially dotatate or MIBG, that can be the problem. They have to visit usually specialized center or tertiary medical center where they will have those methods available. But CT and MRI is in the United States almost around every corner.
Is there a place for interventional radiology specific to paraganglioma metastatic to the liver?
Oh, absolutely it is. This is excellent question, and we can use, for example, cryoablation or radioablation. And this is when, for example, the patient, they have liver lesions, and they, rather than typical surgical procedure, they would like to use the interventional radiologist to remove those lesions. For example, radiofrequency ablation, you put the needle into the tumor, and by heat the lesion will be destroyed. Of course, it depends where the lesion is located, because if the lesion is located close to big vessels in the liver, the lesion cannot be removed by this procedure, because of course there is a lot of heat, and the heat will go also to those vessels around the tumor, and when you destroy the vessels, the patient actually can have very serious bleeding and very serious consequences. It depends where the tumors are located. We use the radiofrequency here at the NIH as the first group in the world to remove actually the paraganglioma from the bone. But there is some interesting paper just now published from Mayo Clinic in the journal which is called Cancers, and they summarize their very interesting and good experience using this type of procedure, and with very good outcomes. So it's accepted method, it's good method. The patients usually recover very well, very quickly, and most of the patients, not all, but most of the patients can go home next day.
Very good. Martha asks, how long should it take blood pressure to return to normal after a Pheo is removed?
Also interesting questions. So when the Pheo is removed, of course you will be in the hospital. If you are in the hospital, you have a pain medication, so you will not measure blood pressure, heart rate so well, because the pain medication will increase, pain medication, the pain will increase your blood pressure, you don't feel comfortable, you are in the hospital, this is not being at home. But usually after 2 or 3 weeks, and especially when the patient is at home after successful surgery, the blood pressure should normalize. And we usually here, at least at the NIH, we always invite patients approximately 5 to 6 weeks after the operation to measure their blood pressure and heart rate. And at that time, 5 to 6 weeks after operation, if the operation was successful and the tumor was removed completely, the blood pressure and heart rate should normalize.
Wow. It appears our time is coming to an end, but I want to ask one more question on behalf of all Pheo patients, including myself. What's on the horizon that can, well, make us excited?
Yeah, so on the horizon that there is, I think that what we have to really focus on are, the new therapeutic options. We know how to diagnose pheochromocytoma and paraganglioma. We know very well how to localize pheochromocytoma, paraganglioma. We know a lot about the biochemistry. We know or we have a good information about the pathogenesis. But what we are missing is the good treatment options, successful treatment options. Not only that 20, 30, 40% of patients will respond, but more patients will respond. I think on the horizon is to use the theranostics together with, for example, the immunotherapy, to use also the immunotherapeutic approaches. There are several interesting immunotherapeutic approaches in the future, to use the different emitters, for example, alpha emitters, to treat, for example, the bone lesions. And of course, in the future, and this is maybe in many, many years, not only to think about the treatment, but to think also about the prevention, how to prevent the development of pheochromocytoma, paraganglioma. And if we reach that it would be absolutely, absolutely fantastic.
One day you'll beat this thing, huh?
Hopefully we will. This is why we are here, and we are dedicated to this disease.
Well, thank you, Dr. Pacak, for this informative session. We'll do our best to see if we can provide answers to all those who submitted questions and we were unable to get to them. Also, we'll make sure your presentation is available along with this entire session online very soon. And to our viewers, please stay tuned for more information coming very soon in our next webinar in early November. Thank you all for coming and watching us tonight, because through this compassionate community, we can continue to provide resources and support to our patients and their families. We need to grow our Pheo Paratrooper Army, and if you're interested in volunteering with the Pheo Para Alliance, please go to the pheopara.org volunteer for more information. A special thanks to the NIH for hosting this webinar. We're very grateful for them. And finally, thanks again to our generous, dedicated partner, Progenics, for making this webinar series possible. Have a good night.